Drugs affecting the autonomic nervous system are divided into two groups according to the type of neuron involved in their mechanism of action. The cholinergic drugs, which act on receptors that are activated by acetylcholine, and the adrenergic drugs, which act on receptors stimulated by noradrenaline or adrenaline. Cholinergic and adrenergic drugs act by either stimulating or blocking receptors of the ANS. Cholinergic drugs that stimulate the receptors are called parasympathomimetics. And the ones that block the receptors are called parasympatholytics. Adrenergic drugs that stimulate the receptors are called sympathomimetics. And the ones that block the receptors are called sympatholytics. From the previous lecture we already know that cholinergic neurons are located in the autonomic ganglia of both parasympathetic and sympathetic, and the postganglionic fibers of the parasympathetic division, the postganglionic sympathetic division of sweat glands, and the preganglionic fibers terminating in the adrenal medulla. In addition, cholinergic neurons innervate the muscles of the somatic system and also play an important role in the central nervous system. Now let's discuss the neurotransmission at cholinergic neurons, or as I'm calling, acetylcholine journey. This journey involves synthese of acetylcholine, storage, release and binding to receptors, degradation and recycling of acetylcholine. Choline is a compound that carries a positive charge, so it cannot diffuse through the membrane of the neuron. So, it needs a transporter to deliver it to the cytoplasm of the cholinergic neuron. And that is done by an energy-dependent carrier system that co-transports sodium. The uptake of choline is the rate-limiting step in acetylcholine synthesis. Then, cholinacetyltransferase catalyzes the reaction of choline with acetylcoenzyme A to form acetylcholine. Then acetylcholine is packaged and stored into presynaptic vesicles. As we discussed before in synaptic transmission video, when an action potential arrived to the nerve ending, voltage-sensitive calcium channels on the presynaptic membrane open, causing an increase in the concentration of intracellular calcium. Elevated calcium levels promote the fusion of synaptic vesicles with the cell membrane and the release of their contents into the synaptic space. Then acetylcholine diffuses across the synaptic space and binds to postsynaptic receptors on the target cell. The postsynaptic cholinergic receptors on the surface of the effector organs are divided into two classes, muscarinic and nicotinic. Binding to a receptor leads to a biologic response within the cell. Then this action is rapidly terminated, because acetylcholinesterase enzyme cleaves acetylcholine to choline and acetate in the synaptic cleft. Choline may be recaptured and reused, and the process is repeated over and over. This is the acetylcholine journey. Cholinergic agonists mimic acetylcholine actions in the body. And they are classified into two main groups, direct-acting and indirect-acting cholinergic drugs. As we knew from the previous lecture, acetylcholine binds to muscarinic or nicotinic receptors on the effector organ producing a response within the cell, and then degraded by acetylcholinesterase enzyme in the synaptic cleft. So we can notice that there are two ways for the cholinergic agonist to work. Either by binding to the receptor, then it'll be called direct-acting cholinergic agonist. Or inhibits acetylcholinesterase, so increase the effect of acetylcholine indirectly, and that is called indirect-acting cholinergic agonist. In this lecture we will discuss the direct-acting cholinergic agonists. The first one of course is acetylcholine itself. It is a quaternary ammonium compound that cannot penetrate membranes. It lacks therapeutic importance because of two reasons. The first one, it has diffuse effects as it is the neurotransmitter of parasympathetic and somatic nerves, as well as autonomic ganglia. And the second, it's rapidly inactivated by cholinesterases. But it can be used locally as an ophthalmic solution. It is available with the brand name, Myocali. Its actions are the same as we discussed before in parasympathetic actions, and that is because it acts on both muscarinic and nicotinic receptors. And the actions in brief are, decrease in heart rate and cardiac output, decrease in blood pressure, and in the gastrointestinal tract, Acetylcholine increases salivary secretion and stimulates intestinal secretions and motility. Bronchoconstriction and increased bronchiolar secretions. In the urinary bladder, increases the tone of the detrusor muscle, causing urination. In the eye, acetylcholine is involved in stimulation of ciliary muscle contraction for near vision, and in the constriction of the circular muscle, causing miosis. Acetylcholine 1% solution is instilled into the anterior chamber of the eye to produce miosis during ophthalmic surgery. To overcome acetylcholine problems, two modifications have been developed. Making a carbamate ester, to resist hydrolysis by acetylcholinesterase, or making beta-methylation, to make the product more selective to muscarinic receptors. Carbachol is an ester of carbamic acid, so it is not hydrolyzed by acetylcholinesterase, although it is inactivated through hydrolysis by other esterases but at a much slower rate. But still has muscarinic and nicotinic actions. Because of its high potency, receptor non-selectivity, and relatively long duration of action, carbachol is rarely used therapeutically, except in the eye as a miotic agent to treat glaucoma by causing pupillary contraction and a decrease in intraocular pressure, and it is available with the brand names, Myostat and isoptocarbachol. And at doses used ophthalmologically, little or no side effects occur, due to lack of systemic penetration. Methacholine has a beta-methyl group, that makes it selective to muscarinic receptors. But still can be hydrolyzed by acetylcholinesterase. Due to its bronchoconstriction activity, it is used to diagnose bronchial hyperreactivity, which is the hallmark of asthma and also occurs in chronic obstructive pulmonary disease. It is available with the brand name Privacolin. Other therapeutic uses are limited by its adverse cardiovascular effects, such as bradycardia and hypotension, which arise from its function as a cholinemimetic. So, why don't we develop a product with both additions, the carbamate ester and beta-methylation? This product is called bethanechol. It is not hydrolyzed by acetylcholinesterase, although it is inactivated through hydrolysis by other esterases. It is selective to muscarinic receptors. Its major actions are on the smooth muscles of the bladder and GI tract. It has about a 1-hour duration of action. It directly stimulates muscarinic receptors, causing increased intestinal motility and tone. It also stimulates the detrusor muscle of the bladder, causing urination. So it is used to stimulate the atonic bladder, particularly in postpartum or postoperative, non-obstructive urinary retention. It may also be used to treat neurogenic atony as well as megacolon. It is available with the brand name Uracolin. But it causes some adverse effects because of its generalized cholinergic stimulation. These include sweating, salivation, flushing, decreased blood pressure, nausea, abdominal pain, diarrhea, and bronchospasm. Atropine sulfate may be administered to overcome severe cardiovascular or bronchoconstrictor responses to bethanechol. And the final drug we'll talk about in the direct-acting cholinergic drug is pilocarpine. The alkaloid pilocarpine is a tertiary amine, and that means it can penetrate the CNS. It exhibits muscarinic activity and is used primarily in ophthalmology. It is not hydrolyzed by acetylcholinesterase. Applied topically to the eye, pilocarpine produces rapid miosis and contraction of the ciliary muscle. It stimulates secretions such as sweat, tears, and saliva. It is used for promoting salivation in patients with dry mouth, which is known as xerostomia. It is available with the brand name Saligan. Pilocarpine is used to treat glaucoma and is the drug of choice for emergency lowering of intraocular pressure of both open-angle and closed-angle glaucoma. Its action occurs within a few minutes, and lasts 4 to 8 hours, and can be repeated. In the previous lecture we discussed the direct-acting cholinergic agonists, and today we'll discuss the indirect-acting cholinergic agonists. As we said, acetylcholinesterase exists in synaptic cleft, and is responsible for cleaving acetylcholine to choline and acetate, and terminating its actions. The indirect acting cholinergic agonists act by inhibiting acetylcholinesterase reversibly or irreversibly, causing accumulation of acetylcholine in the synaptic cleft, so increasing both muscarinic and nicotinic actions of acetylcholine in the body, as well as its actions in the neuromuscular junction and in the brain. First, let's discuss the reversible anticholinesterase agents. The first one is Edrophonium. It is a short-acting acetylcholinesterase inhibitor. Edrophonium binds reversibly to the active center of acetylcholinesterase, preventing hydrolysis of acetylcholine. It is rapidly absorbed and has a short duration of action of 10 to 20 minutes due to rapid renal elimination. Edrophonium is a quaternary amine, so it doesn't cross the CNS. It is used in the diagnosis of myasthenia gravis, which is an autoimmune disease caused by antibodies to the nicotinic receptor at the neuromuscular junction. This causes their degradation, making fewer receptors available for interaction with acetylcholine. That causes abnormal fatigue of skeletal muscles characterized by decreased grip strength, dropped eyelid or nonostosis, and difficulty in chewing, swallowing, lifting objects and holding the head up and speaking. And that depends on the severity of the disease. Intravenous injection of edrophonium leads to a rapid increase in muscle strength. As we said, it is used in the diagnosis not as a treatment because of its short duration of action. It is available with the brand name, Inlin. Overdose may provoke a cholinergic crisis. In this case, Atropine, which is a cholinergic antagonist, is used as antidote. Physostigmine is a nitrogenous carbamic acid ester found naturally in plants, and is a tertiary amine, so it can cross the blood-brain barrier. It reversibly inhibits acetylcholinesterase, so it increases the effect of acetylcholine in the muscarinic and nicotinic sites of the ANS, and the nicotinic receptors of the neuromuscular junction, and also stimulates the cholinergic sites in the CNS. Its duration of action is about 30 minutes to 2 hours, and it is considered an intermediate acting agent. The drug increases intestinal and bladder motility, which serves as its therapeutic action in atonia of either organ. Physostigmine is also used in the treatment of overdoses of drugs with anticholinergic actions, such as atropine. The effects of physostigmine on the CNS may lead to convulsions when high doses are used. Bradycardia and a fall in cardiac output may also occur. Neostigmine is a synthetic compound that is also a carbamic acid ester, and it reversibly inhibits acetylcholinesterase. Unlike physostigmine, neostigmine has a quaternary nitrogen. Therefore, it is more polar, so it does not enter the CNS, and is poorly absorbed from the GI tract, so it is used as injection, and is available with the brand name, prostigmine. It has an intermediate duration of action, usually 30 minutes to 2 hours. It has a strong effect on skeletal muscle, so it is also used to manage symptoms of myasthenia gravis. It is used to stimulate the bladder and GI tract, and also as an antidote for competitive neuromuscular blocking agents. Neostigmine does not cause CNS side effects, as it doesn't enter the CNS. But it has adverse effects of generalized cholinergic stimulation, such as salivation, flushing, decreased blood pressure, nausea, abdominal pain, diarrhea, and bronchospasm. Neostigmine is contraindicated when intestinal or urinary bladder obstruction is present. Pyridostigmine and ambenonium are other acetylcholinesterase inhibitors that are used in the chronic management of myasthenia gravis. They are effective orally, and their durations of action are intermediate 3 to 6 hours and 4 to 8 hours, respectively. Adverse effects of these agents are similar to those of neostigmine. They are available with the brand names, mestinon and midolase, respectively. Patients with Alzheimer's disease have a deficiency of cholinergic neurons in the CNS. This observation led to the development of anticholinesterases that can penetrate the CNS and increase the effect of acetylcholine. Tacrine was the first to become available, but it has been replaced by others because of its hepatotoxicity. Despite the ability of Donepezil, Rivastigmine, and Galantamine to delay the progression of Alzheimer's disease, none can stop its progression. They are available with the brand names, Aricept, Exelin, Razidine respectively. GI distress is their primary adverse effect. Now let's talk about the irreversible anticholinesterase agents. A number of synthetic organophosphate compounds have the capacity to bind covalently to acetylcholinesterase. The result is a long-lasting increase in acetylcholine at all sites where it is released. Many of these drugs are extremely toxic and were developed by the military as nerve agents. Related compounds, such as parathion and malathion, are used as insecticides. Echothiophate is an organophosphate that covalently binds via its phosphate group at the active site of acetylcholinesterase. Once this occurs, the enzyme can be reactivated using pilocarpine, which breaks the bond between the remaining drug and the enzyme, but this treatment should be done right after the exposure to echothiophate. Pilocarpine is available commercially with the brand name, Protopam. Or the enzyme is permanently inactivated, and restoration of acetylcholinesterase activity requires the synthesis of new enzyme molecules, as the phosphorylated enzyme slowly releases one of its alkyl groups, which is called aging. Echothiophate actions include generalized cholinergic stimulation, paralysis of motor function causing breathing difficulties, and convulsions. It also produces intense meiosis. Intraocular pressure falls from the facilitation of outflow of aqueous humor. A topical ophthalmic solution of the drug is available with the brand name, phospholinamide, for the treatment of open-angle glaucoma. However, echothiophate is rarely used due to its side effect profile. And atropine in high doses can reverse many of the peripheral and some of the central muscarinic effects of echothiophate. In the previous lectures we discussed the cholinergic agonists. So, today we'll discuss the cholinergic antagonists. Cholinergic antagonists are those agents that bind to cholinergic receptors, muscarinic or nicotinic, and prevent the effects of acetylcholine and other cholinergic agonists. They are divided into three groups according to their sites of action. To clarify this, let's use that illustration from the autonomic receptors lecture. The first group is the antimuscarinic agents, which are selective blockers of muscarinic receptors causing the effects of parasympathetic innervation to be interrupted. In addition, they block the few exceptional sympathetic neurons that are cholinergic, such as those innervating the salivary and sweat glands. They have little or no action at skeletal neuromuscular junctions or autonomic ganglia as they have nicotinic receptors. They are also known as anticholinergic agents or parasympatholytics. And they are the most clinically useful group of the cholinergic antagonists. The second group is the ganglionic blockers. These agents block the nicotinic receptors of the sympathetic and parasympathetic ganglia. Clinically, they are the least important of the cholinergic antagonists. The third group is the neuromuscular blocking agents, mostly nicotinic antagonists. They interfere with transmission of efferent impulses to skeletal muscles. Now let's discuss the antimuscarinic agents. The first one is atropine. It binds competitively and prevents acetylcholine from binding to muscarinic receptors. And this effect can be reversed by using anticholinesterase agent, leading to accumulation of acetylcholine and increasing its effect. To discuss its actions we have to go back to autonomic receptors lecture, where we knew the effects of parasympathetic innervation on each muscarinic receptor, then reverse all we said then, as atropine blocks these receptors. Now let's discuss atropine actions, uses and its alternative antimuscarinic drugs at the same time. Atropine blocks muscarinic activity in the eye, resulting in mydriasis, unresponsiveness to light, and cycloplegia, which is the inability to focus for near vision. And intraocular pressure may rise, especially in patients with closed-angle glaucoma. So it can be used as an ophthalmic solution, and it is available with the brand name, isoptotropine. but the problem that it has a very long duration of action for about 7 to 14 days. So it has been replaced by shorter acting ophthalmic solutions such as cyclopentolate, which has about 24 hours duration of action. Tropicamide, which has about 6 hours duration of action. Atropine decreases the tone and motility of the GI tract, but it does not affect the production of hydrochloric acid significantly, so it can't be used for peptic ulcers but can be used as an antispasmodic drug. But it is not the best, as the dose used to treat spasms also reduce saliva secretion, ocular accommodation, and urination. So it has been replaced by a more selective agent. Hyoscine-butyl bromide. It is used as antispasmodic in case of intestinal, renal or biliary spasms. It is available with the brand name, Buscopan tablets and injection. Atropine also causes bronchodilation and decreased bronchial secretions. But it has been replaced by agents that are used as inhalation and does not have any systemic effects, such as ipratropium and tiotropium, which are known commercially as Atrovent and Spiriva, respectively. These agents are approved as bronchodilators for maintenance treatment of bronchospasm associated with chronic obstructive pulmonary disease. Ipratropium is also used in the acute management of bronchospasm in asthma. Tiotropium is administered once daily, a major advantage over ipratropium, which requires dosing up to 4 times daily. Atropine causes relaxation of detrusor muscle of urinary bladder, causing urine retention. So it can be used for overactive bladder. But it has been replaced by agents that are selective to muscarinic receptors in the bladder, such as dariphenazine, Physotoroidine, oxybutynine, solifenazine, Tolterodine and Trospium chloride, that are known commercially as Enablex, Toviaz, Ditropan, Vesicare, Ditrol, and Sanctura, respectively. But they still have some side effects including dry mouth, constipation, and blurred vision. Atropine increases the heart rate, known as tachycardia. So it can be used to treat bradycardia of varying etiologies. And it blocks muscarinic receptors in the salivary glands, producing dryness of the mouth. It also decreases secretions of sweat and lacrimal glands. Inhibition of secretions of sweat glands can elevate body temperature, which is dangerous especially in children. Atropine can also be used as antidote for cholinergic agonists in case of organophosphate, insecticides or nerve gases poisoning, and overdose of clinically used anticholinesterases such as Physostigmine. It also can be used in treating central toxic effects of anticholinesterases as it can enter the CNS. Adverse effects of atropine depend on the dose. It may cause dry mouth, blurred vision, tachycardia, urine retention, and constipation. Effects on the CNS include restlessness, confusion, hallucinations, and delirium, which may progress to depression, collapse of the circulatory and respiratory systems, and death. Low doses of cholinesterase inhibitors, such as Physostigmine, may be used as antidote to atropine toxicity. Other antimuscarinic agents are Scopolamine, produces effects similar to those of atropine. But it has a greater action on the CNS and a longer duration of action as compared to atropine. It is one of the most effective anti-motion sickness drugs available. And it is available as a topical patch that provides effects for up to 3 days. Scopolamine is also used for post-operative nausea and vomiting. It also has the unusual effect of blocking short-term memory. It produces sedation, but at higher doses, it can produce excitement. It may also produce euphoria and is susceptible to abuse. Benztropine and trihexyphenidyl, which are known commercially as Cogentin and Artan, respectively. They are useful as adjuncts with other anti-Parkinsonian agents to treat Parkinson's disease and other types of Parkinsonian syndromes, including antipsychotic-induced extrapyramidal symptoms. In the previous lecture we said that cholinergic antagonists are divided to 3 groups. The antimuscarinic group, which we already discussed. And the other two groups are the ganglionic blockers and the neuromuscular blockers. Today we'll talk about the ganglionic blockers, nicotine and smoking. Ganglionic blockers act on the nicotinic receptors of both parasympathetic and sympathetic autonomic ganglia. Thus, these drugs block the entire output of the autonomic nervous system at the nicotinic receptor. Therefore, ganglionic blockade is rarely used therapeutically, but often serves as a tool in experimental pharmacology. The most important example of this group is nicotine, which is the active ingredient in tobacco. It is found in cigarette smoke combined with the tars and carbon monoxide. Nicotine is second most widely used CNS stimulant after caffeine, and it is second most abused drug after alcohol. In low doses, nicotine causes ganglionic stimulation by depolarization. And at high doses, nicotine causes ganglionic blockade. Nicotine receptors exist at a number of sites in the CNS, which participate in the stimulant actions of the drug. Cigarette smoking or administration of low doses produces stimulation effects that result from increased release of neurotransmitters. For example, enhanced release of dopamine and noradrenaline may be associated with pleasure, arousal and appetite suppression. High doses of nicotine result in central respiratory paralysis. The peripheral effects of nicotine are complex. Stimulation of sympathetic ganglia as well as of the adrenal medulla increases blood pressure and heart rate. Thus, use of tobacco is particularly harmful in hypertensive patients. Nicotine-induced vasoconstriction can decrease coronary blood flow, adversely affecting patients with angina. Stimulation of parasympathetic ganglia also increases motor activity of the bowel. At higher doses, blood pressure falls and activity decreases in both the GI tract and bladder musculature, as a result of a nicotine-induced block of parasympathetic ganglia. Let's talk about the pharmacokinetics of nicotine. Because nicotine is highly lipid-soluble, so it is readily absorbed through the oral mucosa, lungs, GI mucosa, and skin. More than 90% of the nicotine inhaled in smoke is absorbed. Nicotine crosses the placental membrane and is secreted in the breast milk. By inhaling tobacco smoke, the average smoker takes in 1 to 2 milligrams of nicotine per cigarette. And the acute lethal dose is 60 milligrams. Clearance of nicotine involves metabolism in the lung and the liver and urinary excretion. Tolerance to the toxic effects of nicotine develops rapidly, often within days. It has a lot of adverse effects including irritability and tremors that happens due to the CNS effects of nicotine. It may also cause intestinal cramps, diarrhea, and increased heart rate and blood pressure. And also it may increases the rate of metabolism for a number of drugs. Nicotine represents a serious risk factor for lung and cardiovascular disease, various cancers, and other illnesses. So it is not currently used therapeutically, except in smoking cessation therapy. As with the other drugs in this class, nicotine is an addictive substance, and physical dependence develops rapidly and can be severe. Withdrawal of nicotine is characterized by irritability, anxiety, restlessness, difficulty concentrating, headaches, and insomnia. Appetite also is affected, and GI upset often occurs. The transdermal patch, chewing gum, lozenges and inhalation containing nicotine, such as Nicotrol and Nicorette, have been shown to reduce nicotine withdrawal symptoms and to help smokers stop smoking. For example, the blood concentration of nicotine obtained from nicotine chewing gum is typically about 1/2 the peak level observed with smoking. Antidepressants may also be used to reduce the craving for cigarettes. Lastly, you should know that smoking cessation programs that combine pharmacologic and behavioral therapy are the most successful in helping individuals to stop smoking. In the previous two lectures we discussed two groups of the cholinergic antagonists, the antimuscarinic agents and the ganglionic blockers. And today we'll discuss the last group, the neuromuscular blockers. These drugs block cholinergic transmission between motor nerve endings and the nicotinic receptors on the skeletal muscle. They have some chemical similarities to acetylcholine. And they are divided into two groups according to their mechanism of action. The non-polarizing type that acts as antagonists, and depolarizing type that acts as agonists at the receptors on the end plate of the neuromuscular junction. Neuromuscular blockers are clinically useful during surgery, to facilitate tracheal intubation and provide complete muscle relaxation at lower anesthetic doses, allowing for more rapid recovery from anesthesia, and reducing postoperative respiratory depression. To be able to discuss the non-polarizing and depolarizing neuromuscular blockers, first we should know what is the normal condition of the signal transmission at the neuromuscular junction. The receptors at the neuromuscular junction are channel link receptors, as we discussed in the receptors types lecture. That means when acetylcholine binds to its receptor, the ion channel that is linked to the receptor opens, allowing sodium ions to pass through and enter the cell, causing depolarization and initiation of the response within the cell. So, what are the non-polarizing neuromuscular blockers? They are just antagonists at these receptors. At low doses, these agents compete with acetylcholine at the nicotinic receptors and block them, leading to prevention of depolarization of the muscle cell membrane and inhibition of muscular contraction. Their competitive action can be overcome by administration of cholinesterase inhibitors, that we discussed before, such as Neostigmine and Edrophonium, which increase the concentration of acetylcholine in the neuromuscular junction. Anesthesiologists employ this strategy to shorten the duration of the neuromuscular blockade. In addition, at low doses the muscle will respond to direct electrical stimulation from a peripheral nerve stimulator to varying degrees, allowing for monitoring of the extent of neuromuscular blockade. And at high doses, non-polarizing agents can block the ion channels of the motor endplate. This leads to further weakening of neuromuscular transmission, thereby reducing the ability of cholinesterase inhibitors to reverse the actions of the non-polarizing blockers. So with this complete blockade, the muscle does not respond to direct electrical stimulation. The first drug known to block the skeletal neuromuscular junction was curare, which native South American hunters of the Amazon region used to paralyze prey. The development of the drug tubocurarine followed, but it has been replaced by other agents with fewer adverse effects, such as cisatracurium, pancuronium, rocuronium, and vicuronium. And as we said, the neuromuscular blockers are administered during surgeries along with anesthetics, allowing to produce muscle relaxation with lower doses of anesthetics. So patients recover quickly and completely after surgery. But they should not be used to substitute for inadequate depth of anesthesia. So, how muscles respond to non-polarizing neuromuscular blockers? Actually, not all muscles are equally sensitive to blockade by competitive agents. Small, rapidly contracting muscles of the face and eye are most susceptible and are paralyzed first, followed by the fingers, limbs, neck, and trunk muscles. Next, the intercostal muscles are affected, and lastly the diaphragm. And the muscles recover in the reverse manner. Let's talk briefly about the pharmacokinetics of this group. All of these agents are injected intravenously or occasionally intramuscularly since they are not effective orally. These agents are positively charged, as they possess 2 or more quaternary amines in their structure, that prevent their absorption from the gut, and they do not enter cells or cross the blood-brain barrier. Pancuronium is excreted unchanged in urine. Cisatracurium is degraded spontaneously in plasma and by ester hydrolysis, so it is the only non-polarizing neuromuscular blocker whose dose does not need to be reduced in patients with renal failure. And it is often used in patients with multisystem organ failure because its metabolism is independent of hepatic or renal function. The aminosteroid drugs vicuronium and rocuronium are deacetylated in the liver, and their clearance may be prolonged in patients with hepatic disease. These drugs are also excreted unchanged in bile. The choice of an agent depends on the desired onset and duration of the muscle relaxation. Depolarizing blocking agents, such as acetylcholine, work by depolarizing the plasma membrane of the muscle fiber, similar to the action of acetylcholine. However, These agents are more resistant to degradation by acetylcholinesterase, so the depolarizing agent persists at high concentrations in the synaptic cleft, remaining attached to the receptor for a relatively longer time and providing constant stimulation of the receptor. So phase 1, the depolarizing agent first causes the opening of the sodium channel associated with the nicotinic receptors, which results in depolarization of the receptor. And this leads to a transient twitching of the muscle. Then phase 2, membrane repolarizes, but receptor is desensitized to the effect of acetylcholine. Continued binding and continuous depolarization renders the receptor incapable of transmitting further impulses, causing resistance to depolarization and flaccid paralysis. As with the competitive blockers, the respiratory muscles are paralyzed last. 6-Acetylcholine initially produces brief muscle fasciculations that cause muscle soreness. This may be prevented by administering a small dose of non-polarizing neuromuscular blocker before the 6-Acetylcholine. Normally, the duration of action of 6-Acetylcholine is extremely short, due to rapid hydrolysis by plasmacetylcholinesterase. However, 6-Acetylcholine that gets to the neuromuscular junction is not metabolized by acetylcholinesterase, allowing the agent to bind to nicotinic receptors. And redistribution to plasma is necessary for metabolism. Because of its rapid onset of action, 6-Acetylcholine is useful when rapid intratracheal intubation is required during the induction of anesthesia, and is also used during electroconvulsive shock treatment. It is injected intravenously. And it is sometimes given by continuous infusion to maintain a longer duration of effect. Drug effects rapidly disappear upon discontinuation. It has some adverse effects such as hyperthermia. 6-Acetylcholine can potentially induce malignant hyperthermia in susceptible patients. Apnea. Administration of 6-Acetylcholine to a patient who is deficient in plasmacholinesterase or who has an atypical form of the enzyme, can lead to prolonged apnea due to paralysis of the diaphragm. Hyperkalemia. 6-Acetylcholine increases potassium release from intracellular stores,